Welcome to Why is My Pain Getting Worse? Central Sensitization, Diagnosis and Management. We're glad you're here. My name is Angie Hunt, Project Manager with the Canadian Institute for the Relief of Pain and Disability, and I'll be moderating the webinar today. This webinar is made possible through the support of the Community Gaining Grant Program through the BC Government, as well as donations and memberships to CIRPD. We thank our program partners, Pain BC, Education Advisory Committee, and speakers who contribute to this webinar series. While you're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing and to answer any questions you have related to the presentation. We'll collect questions submitted throughout the presentation and follow the presentation with a Q&A based on the questions submitted. Following the webinar, any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website within a week, along with the slides. You'll be emailed direct links for all of these items when they are available. As I mentioned, my name is Angie, and I'll be moderating the webinar and Q&A session. Our presenter today is Dr. Joel Kailia. Dr. Joel Kailia was born in Montreal, Quebec, and grew up in Toronto. He received a Bachelor of Science from McGill University in Physiology and Psychology and a master's degree from the University of Toronto in Neuroscience and the Study of Pain. He trained in family medicine at UBC and shortly afterward moved to Nelson. Dr. Kailia started the Community First Medical Clinic in 2008 with a mandate to help those who had been marginalized by our current healthcare system. He has also helped to start 2 other medical clinics, the Men Clinic for students at LV Rogers High School and the 10th Street Clinic for opiate replacement in Castlegar. In 2013, Dr. Kailia opened the KPAC Clinic without the help from the local health authority. This multidisciplinary clinic for patients in the Kootenay boundary region with pain and/or addiction issues. When he's not in the clinic, Dr. Kailia can be found riding his bicycle, doing yoga, skiing, and enjoying the great outdoors in the Kootenays. Dr. Kailia recently trained in interventional pain therapy and took the pain certificate program to the University of Edmonton. His philosophy is a holistic approach to pain and addiction assessment and management. And now I'll turn it over to Joel.
Thank you, Angie. So welcome, and for the next 45 minutes, I'll be talking about this concept of central sensitization. So first I'm going to talk about who I am, the objectives of the talk. We're going to talk about a case, the Catastrophizer. We're going to go through some of the basic science around pain, and then talk about central sensitization, what to watch out for, and how to diagnose it. So first, a little bit about me, because you can't see me. So this is me at work, and I work in the Community First Co-op in beautiful Nelson, BC, and the name of my multidisciplinary clinic is Rise BC. So we're located in the West Kootenay Mountains in British Columbia, and here is Nelson, BC, tucked away in the mountains. And when I'm not working, you might find me on top of one of these mountains skiing the fresh powder, which is just starting to fall now in mid-September. So I went to medical school in Toronto, and during my training, I was taught that pain was the 5th vital sign, along with blood pressure, heart rate, and that pain should be treated aggressively in the emergency department. And unfortunately, that model of pain being a vital sign that should be brought down, just like blood pressure, was then extended to the chronic pain situation. And of course, the chronic pain situation is way more complex. And if we just treat pain as a number and try to get it down, we end up using a lot of medications, such as OxyContin. And this has led to the fentanyl crisis that we're all keenly aware of, which is plaguing our society at the moment. So I started a non-for-profit called Rise Above Pain, whose mandate is to change the way we look at pain and to treat it not as a number, but as a multifactorial problem that has to be attacked in multiple ways. And as part of this non-for-profit, myself and my colleagues wrote a self-management manual that is available for free for patients and physicians on my website, riseabovepain.ca. And this is designed as an 8-week course to teach practitioners and patients alternative ways to treat their pain outside of the traditional medication, surgery, and injections, etc. So the objectives of this talk is to teach you how to recognize this concept of central sensitization, to understand why some of the traditional interventions may actually worsen central sensitization, to talk about some of the management strategies for this condition, and to understand why interdisciplinary clinics are the gold standard for this condition, and what to do if you don't have access or you don't work in a community that has an interdisciplinary pain clinic. In terms of my disclosures, I'm not receiving any money from this talk or from pharmaceutical companies. I'm not selling anything. This manual is available for free, as I've said, on my website, RiseBC, riseabovepain.ca. So first, let's talk about the scope of the problem. Chronic pain is a huge issue. In British Columbia, it's estimated that 1 in 5 people suffer with chronic pain. And some studies have shown that this is up to 1.5 billion people worldwide. And these folks have a quality of life that is equal to or worse than patients with palliative care. For you as a family doctor or whatever profession you're working in, pain is probably one of the most common reasons for patients to present to you. And the cost in Canada is staggering. It's $50 to $60 billion per year. It's more than cardiovascular, respiratory, digestive, metabolic diseases, injuries, poisoning, and cancers combined. So let's take this to a real case, Kate the Catastrophizer. Kate is a 42-year-old dental hygienist who's separated and has twin girls. So Kate woke up one night with the fire alarm going off in her house, and as she struggled to get out of the house and get her kids out of the house, she stepped on a pin that had fallen off of a bulletin board. Now, fortunately, the fire alarm was a false alarm, but unfortunately, the pin had injected a little bit of bacteria into her foot, which then became infected. She had to go to the emergency department and have an incision and drainage. This led to several courses of antibiotics, several investigations, and by the time I saw her, she was having pain all over, top to bottom, with the worst pain in her left foot, calf, and the gluteal region. She has a stressful lifestyle at this point. Although she was previously healthy, she's now turned to convenience foods. She used to exercise, she used to run, but she's no longer running because of the pain. Her sleep she describes as terrible. She feels depressed, anxious, and fatigued. So in my clinic, I use as one of the intake tools, we use the Brief Pain Index. My first pearl from this talk is that if you are treating chronic pain, that you use a tool such as this one in order to get a more clear picture of what's going on in your patient. So the Brief Pain Index has a diagram where the patient can shade in where they're having their pain, and it asks them where their pain is worse, what makes it worse, what makes it better, and what they're doing. And then it also has a multi-dimensional scales that look at not just the rating of pain, but also how it's impacting their life. So it gives you a more well-rounded look at a patient's pain. So the one thing to note about Kate is that her diagram is fully shaded. And this is the first clue that there's something going on in that might be central sensitization. The other thing I talk about is the right shift, where patients are circling 9s and 10s out of 10s in terms of the pain effect on their function. And this is also another red flag. Physical exam on Kate shows that she's diffusely tender to palpation. We call this allodynia. So everywhere you touch her on her body, she's quite tender. It's especially bad in her lateral gluteal region and her calf. As she's walking, you notice an antalgic gait. She's shuffling, and her left foot is externally rotated. Neurological exam shows a weakness in her left dorsiflexion of the ankle. She has hyperalgesia and allodynia in the left plantar fascia. She's already had a CAT scan of her back because of the radicular nature of her symptoms, and an EMG, which were normal. Labs did not show any metabolic issues. When she came to me, she was taking triptans for a headache on an as-needed basis, and using Tylenol number 3 as needed 2 to 3 times a day, as well as Zopiclone for sleep. So my pearl in terms of this history is if someone is presenting with diffuse tenderness, spreading pain, sleep disturbance, and mental cloudiness, the thing that should pop up in your head is central sensitization. So let's talk about what happened to Kate. So first of all, we have to back up and talk about what pain is. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. Now, this definition is significant because you do not actually need tissue damage in order to have pain. Pain can be an experience of the brain. So no talk on pain is complete without René Descartes' famous depiction of what we thought pain was in the 1600s. So René Descartes imagined a 1-to-1 ratio where a stimulus, such as a fire, stimulated a pain thread, in this case in the foot, which then ascended to a valve in the brainstem, opening up the valve and letting in animal spirits, causing a pain sensation, which then would cause withdrawal of the foot. In this situation, the removal of the fire would cause the pain to go away. Now, of course, we know that this is much too simplistic. So this figure that I made shows the job of the brain in terms of deciding what is going on in the body. So we have down here Kate's brain is just trying to decide what to do with the information as she steps on a pin running out of her house. So the brain's job is to gather information, such as there's a pin in my foot, and there might be a fire. Then to analyze the threat and to see which one's more important. Is it the pin that's more important, or is it the fire that's more important? In her case, she decides that the fire is more important, and the brain chooses the response. Let's get out of the house. And the brain then tells the body to execute that response. So in the case of Kate, she may not have even noticed the pin until she was safely out of the house, and that trauma had dissipated. So the top layer, where pain is being perceived, it's quite important. So pain is being perceived in the emotional and the attention parts of the brain. So pain causes the brain to focus on what's going on in order to cause a response, and it causes an emotional reaction in order to cause you to do something. In the case of Kate, to escape. And then this is known as neuroplasticity. The brain is actually learning to associate a stimulus with a specific response. So there's a critical time when this neuroplasticity can start to become almost permanent. And this is in the subacute phase. This is between 6 weeks and 3 months. And in Kate's case, during this time, she was undergoing investigations, antibiotics. She was having a CT scan. She was being referred to a surgeon. And her brain is still undergoing these changes, and it's still learning, and it has not unlearned that she is now safe. The attention parts of her brain, the emotional parts of her brain, and the pain in her foot are becoming attached. They're changing in a plastic nature. So my pearl here is that it is during this subacute phase that we need to intervene with the kind of things that I'm going to talk about in the second half of this talk in order to prevent chronic pain from occurring. So as I said, with Kate, by this time, her infection has resolved, but she's continuing to have diffuse pain. So because of this pain, she stopped running. She's also stopped working. She doesn't feel like she can work with this much pain. She doesn't see her friends anymore. As I said, her eating habits have changed. She cannot sleep and she can't concentrate. She's becoming anxious and irritable. And as a result, she sees her physicians, and they're increasing her pain pills, they're increasing her sleep pills, trying to get her back to normal. So you can see that things are starting to compound for Kate. So the other main thing that's going on in Kate's body is this fight or flight, or the sympathetic nervous system. So we were all taught in medical school that the sympathetic nervous system kicks in when the body has to defend itself from potential damage or death. And it releases epinephrine and cortisol, which goes to all the organs of the body, getting the body, the brain, and the muscles ready for action. But what we see here in the case in cases of chronic pain is that with the initial fight or flight from a trauma, such as the fire in our house, instead of when the trauma ends, instead of Kate going back into the parasympathetic or safety part of the autonomic nervous system, she gets stuck in the sympathetic or fight or flight part of the nervous system. And then over time, she can actually enter the dorsal vagal or freeze part of the curve. And this is where we see patients in the chronic pain clinic with essential sensitization. They've been in the fight or flight, sympathetically aroused state for so long that they have become dissociated, they're getting depression, their pain threshold is lower, they feel hopeless, shut down. So my pearl here is that prolonged activation of the sympathetic nervous system leads to central sensitization and the freeze response, where patients feel that they are not able to do anything to get out of their current situation. Our job is to take patients like Kate back down through the deactivation state to the safe ventral vagal or parasympathetic system using the techniques that I'm going to talk about. So just a little more science here. In the acute stress situation, let's say when Kate steps on a pin, the hypothalamic pituitary axis releases several hormones in order to allow the organism to escape from the potential danger. One is cortisol, which activates the sympathetic nervous system. The other is beta endorphin, which is our body's natural opioid and is about 30 times stronger than morphine. So the beta endorphin allows pain to be blocked and Kate to run out of the house without feeling the pin in her body. Usually, though, this is resolved and the system goes back to normal. We have a feedback loop and the hypothalamic pituitary axis is able to relax. But in cases of chronic stress, where the patient does not feel that the trauma is resolved, we have prolonged cortisol and beta endorphin. And you can see that the font here is smaller. Over time, the hypothalamic pituitary axis is overactivated, and so we have an exhaustion of the cortisol and beta endorphin system. So with lack of cortisol, this is when we enter the freeze state. And with lack of beta endorphin, this is when we become hypersensitive to pain. And so from these chronic stress situations, this is when we get fatigue, disability, and all of the sequelae of chronic pain and central sensitization. So my pearl here is that chronic pain patients have less endogenous opioids and cortisol, and therefore more pain sensitization, fatigue, and other symptoms. So lastly, in terms of the yellow flags for which of these patients are going to go on to have chronic pain, because we know that two patients with the same trauma, they're not necessarily both going to end up with chronic pain. So there's lots of evidence out there now that early adverse childhood experiences, such as that are listed here, can predispose a person to have this overreaction in the sympathetic nervous system and the plastic changes that are causing central sensitization. So this has been proven over and over again that physical abuse, emotional abuse, having substance abuse or mental illness in the home, or even witnessing abuse can predispose a person to developing a multitude of conditions such as depression, anxiety, and chronic pain. How does this work? When a child is exposed to an adverse childhood event, cortisol is released as a sympathetic response. And as we've said a few slides ago, when cortisol is over-released for years and years and years, the system eventually becomes fatigued. And when the system becomes fatigued, when a person is then re-exposed to another trauma, in this case stepping on a pin, running away from a fire alarm, the body is not able to deal with that stress. We have stress dysregulation, and then a risk of chronic pain, fatigue, and inflammation. So early adverse childhood events lead to a dysfunction in the hypothalamic pituitary axis, which is then predisposed to depression, anxiety, and chronic pain. Just for review, this is the hypothalamic pituitary axis, and we know that in children who have been exposed to adverse early childhood events, that the pituitary gland is actually smaller and is not able to release as much ACTH, and therefore not able to stimulate as much cortisol. So we have a relative cortisol deficiency when they are adults, and they're not able to respond to stressors as well as someone who is not exposed to early childhood events. Finally, in terms of the science, I want to talk about microglia. Now, previously I was taught that microglia were the glue, the structural cells that held neurons together in the brain and the spinal cord, and that was it. We now know that microglia are actually inflammatory cells, and they act as the gatekeepers or the gain in the system in the brain and the spinal cord. As this study shows, in rats who are exposed to a trauma early in their life, the microglia become hypersensitized. So this is a normal, on the top are the normal microglia. And when they're then exposed to a painful stimulus, they react normally. But if they're exposed to a trauma in a critical period, the microglia become hypersensitized. And this leads in later life, when they are exposed to a challenge such as pain, to an over-response of the microglia, and inflammation in the nervous system, and hypersensitization. So, adverse childhood experiences cause microglial dysfunction, which then predisposes to sensitization. It's kind of like the nervous system is in an inflammatory state and is ready to respond with an overreaction to a painful stimulus, resulting in a turning up of the response to pain, which we call central sensitization. So what are the symptoms of central sensitization? Well, we've talked about some of the risks and the triggers to central sensitization, which include genetics, experiences, also exposure to substances like alcohol and other substances of abuse, medications, diet, lifestyle, an inflammatory diet, infections, etc. Those are all yellow flags or risks, which when combined with a trauma, whether it's psychological, emotional, or physical, lead to a host of different symptoms that include pain, but also include headaches, fatigue, memory, dizziness, palpitations, gastrointestinal symptoms like irritable bowel, bladder symptoms, all of these symptoms that we see in central sensitization. We see patients who are sensitive to barometric pressure, who have a wide variety of different symptoms can be involved once the nervous system is hypersensitive. So the conditions that are associated with central sensitization syndromes are the ones that you see in your office that are the difficult ones to manage. And these include chronic fatigue syndrome, fibromyalgia, chronic headaches and migraines, irritable bowel syndrome, CRPS, chronic regional pain syndrome, osteoarthritis, it's actually a central sensitization syndrome, et cetera, et cetera. So all the difficult pain conditions and multi-system diseases that we see that don't have an explanation to them, often these are central sensitization syndromes. So if we take René Descartes' view of how pain is generated, we now have to update that. We have the integrative theory of pain that says that not only is there processing in the nervous system, but there's all these other things that are affecting how someone responds to a painful stimulus or to a painful event, such as fear, substance use, the culture that they grew up in, how they were parented, early childhood experiences, et cetera, et cetera. So we need to put this integrative theory together to come up with a management strategy that addresses these issues and not just treating the symptoms. In summary, chronic central sensitization is a situation where we have sympathetic nervous system burnout, we have an inflamed nervous system, and we have a neuroplastic change in the brain that associates these with pain. And the brain has learned that pain and the symptoms are related. And it causes a number of symptoms, including pain, fatigue, and symptoms in almost any system. So that's the bad news. Now we're going to spend the rest of the time talking about how we can manage these very complex patients, how you can do this in a busy office, and how you can do it hopefully without writing medications or with writing less medications. So we know that the gold standard to treating these complex patients are interdisciplinary clinics. Now the downside to this is that these clinics are difficult to access. The waiting lists can be quite long. They're expensive to run, as I know, running a private one myself, and they can be of variable quality. And the key thing is they're generally not able to see patients during that key subacute phase when the neuroplasticity is happening and patients are becoming chronic. Usually they can have wait lists of up to years, and by that time things have already gone past the threshold. So the question is, what can you do in your busy office that can help these patients? So our approach to management is listed here, and I've put an icon here of the manual that I talked about. Whenever you see this icon in the upcoming slides, that indicates that the worksheet that I'm going to talk about is available in the manual that you can print out and hand to your patients. So the first thing we want to do is acknowledge the symptoms and the suffering that patients are undergoing. We want to give them education, which we can do ourselves, or we can redirect them to websites or this manual. We want to encourage active versus passive therapies. And then we want to refer to appropriate resources, whether they're in the traditional medical system or allied health professionals. We're going to talk about the active versus the passive approaches. We're going to delve a little bit into cognitive behavioral therapy, talk about SMART goals, yoga and exercise, mindfulness, and then we're going to touch briefly on some of the medications, and if you are going to prescribe medications, which ones might be the least harmful to patients. So back to Kate. So Kate was doing pretty well. Her symptoms had settled down a bit. She was feeling better, so she tried to go for a run because that was what gave her pleasure in life. Now, when she presented to me this time, even though her gait was off, she went for a run, and she presented with severe back pain and calf pain. And of course, this was affecting her sleep. She was still not working, and she continues to have this pain all over. So what are we going to do with Kate? The most important thing that we can do when we see these patients who are going on and on about their symptoms and we're feeling overwhelmed is to make an empathic statement. Studies have shown that the therapeutic relationship between the practitioner and the patient is the #1 predictor of a patient doing well. So it only takes a second. These can be learned. If this is not your natural way to practice, you can memorize one of these, or you can make it to your own. So even something as simple as, I believe you, or that sounds awful, for the next 15 minutes we'll work together on some solutions, or this is getting worse, let's try to get to the bottom of it together, makes the patient feel heard and can help them on the road to getting better. So that's #1. #2 is cognitive behavioral therapy. Now this is a whole course in itself, but I just wanted to introduce the concept of cognitive behavioral therapy. Cognitive behavioral therapy states that feelings, thoughts, and behaviors are intertwined, and that one cannot be changed without changing the others. Patients will tend to focus on feelings, how they're feeling. They're feeling tired, they're feeling stressed, they're feeling in pain, they're depressed, they're anxious. Now, counselors can try to help them with their thoughts in terms of interpreting their feelings, but my argument is that we can concentrate as busy GPs on their behaviors, and if we can change their behaviors, and if we can focus on their behaviors, we can then change their feelings and their thoughts. So patients tend to focus on feelings. Docs should try to focus on behaviors. So when we talk about patients' behaviors, we can talk about passive versus active. So a lot of our patients will find that are stuck in passive behaviors. They're wanting things to be done to them. They're looking for investigations, for some sort of medication, a surgery, something that's going to be done to them to help them get better. And I think it behooves us to try to move them towards the active side of this curve, which we call self-management, towards things such as meditation, physiotherapy, exercise, and yoga. Things that patients are doing for their own good and are going to help them get better. So just by encouraging these active therapies, we can help patients in their recovery and improve their self-management. Many patients are stuck in one of these two cycles of either pushing and crashing or resting too much. So we see in Kate's situation, when she recovered from her pain, she went and then did excess activity. She went and ran again, which then strained her muscles, in this case, the glutes, the calf, and the hamstring, which then caused pain again. So we see that Kate is stuck in this pattern. Other patients you may find are in the too passive end, where because of the pain, they rest, they restrict their activities, their muscles get weak, which then causes more pain. So our job is to try to break these cycles. And the way we can break these cycles is using a concept called pacing. And this is a handout that you can give to your patients. It can help them basically pace themselves so that they don't hurt themselves and they can kind of build up towards their activities. So feel free to give this out to your patients and help them pace themselves. So how about if a patient cannot come up with an active thing to do? Well, this is a handout that you can give them called SMART goals. So what are SMART goals? SMART goals are goals that are specific, measurable, achievable, relevant, and time sensitive. Now, this worksheet helps patients come up with a specific goal and to ask themselves these questions and to see if a goal is right for them. I filled out on the right for Kate what I thought Kate would say. So at first she said running, and then I tried to bring that down and say, well, maybe running is not the best thing for you. It's hurt you in the past. Okay, how about walking? So she was okay with walking. We're going to measure it using her Fitbit, and to make it achievable, she's going to have to do some things in her life. She's going to have to find someone to take care of her kids. Is it relevant? Yes, she feels, we talk about the fact that walking will get her to her goal of running. And time bound, we're going to set a specific amount of time and a specific number of times per week. So once a patient has come up with a SMART goal, I recommend giving them a worksheet such as this one. This is almost like a prescription for exercise, where a patient puts in their intention for the week, how often they're going to do it, how many times they're going to do it, and then this can be looked at the next visit to see how a patient is doing. Now, the key here is that a patient's confidence in how likely they are to complete this task should be a 7 or more out of 10. If it's less than a 7, then we need to relook at that goal. We need to bring it down a notch and make it more achievable, because the last thing we want is for our patients to fail. If a patient's having a hard time thinking of what their goals are, sometimes they need to brainstorm. A lot of patients will have long-term goals. In Kate's case, she wants to be able to run again. But we need to break that down into what are her intermediate goals, her short-term goals, and her daily tasks. And when we can break down long-term goals into daily tasks, then we can come up with a SMART goal that someone can do on a daily basis in order to get better. Finally, I wanted to put a plug in for Pain BC's program called Live Plan B. Sorry. This is a website where a patient can log in, and it kind of walks them through the SMART goal process. And it also will hold them accountable. It'll email them and check on their progress. And if desired, they can also send a report to their physician to tell their physician how they're doing. So if patients are having trouble with setting and maintaining SMART goals, maybe try pointing them towards Pain BC. Yoga. So 5,000 years, can't be wrong. Yoga has been shown time and time again to reduce not only physical symptoms such as blood pressure, stress response, inflammation, and disability, but also chronic pain, anxiety, and depression. Now, studies, the systematic reviews do not show that one type of yoga is any better than other types of yoga. Unfortunately, a lot of the studies are small, but they do consistently show that yoga therapy does reduce disability and improve pain. It works on both the mind, the body, and the spirit. Yoga involves three main things: postures, breathing, and meditation. And these can be done in any combination. And the one caveat I would say about recommending yoga to your patients is that some classes that are for anybody in town can sometimes be a problem. Not all yoga teachers have the same training, and patients can sometimes have an exacerbation of the pain if they go to a yoga class. So I do recommend either a yoga therapist or some sort of yoga that has, with a teacher that has some training in how to modify activities for a specific pain condition. Warn your patients to talk to the yoga teacher before the class to let them know what their limitations are, so that if there are modifications that can be done, they can tell them about that. In our manual, we have 8 yoga poses, which we feel are most patients can do. So you feel free to hand this out. It has a description of the pose, how to modify the pose, when not to do the pose, and how often to do it. And if patients can do this at home, I think that's a great option for them. Now, yoga is not the only type of physical activity that's been shown to improve pain. In fact, any exercise has been shown to improve pain. And we've included 8 exercises that you can recommend to your patients with modifications that they can also do at home to work on their core and to work on their balance and to work on their self-confidence. Mindfulness. So mindfulness for some people is this. For other people, it's a calm walk along the beach. And in our course, we talk about, we do an exercise with a raisin, where we concentrate on a raisin, its smell, its texture, its flavor. And all of these things are paying attention to the present moment. Mindfulness was popularized in the West by John Kabat-Zinn, and there's been a lot of research done in mindfulness in terms of it reducing the symptoms of depression, anxiety, and pain. Mindfulness is usually presented in an 8-week mindfulness-based stress reduction course. There might be an MBSR course in your local community. If there's not, you can look, there's a free online resource called palousmindfulness.com. There's also a workbook that's available by Teasdale. Records are available here. In our manual, we have a take-home practice that combines yoga and mindfulness, so the patients can combine the two. It involves getting into a comfortable position, noticing the breath, and breathing. And what this is doing is, if patients get into this position and do this breathing, what it is doing is allowing them to come from the freeze part down through the fight or flight and get them into the relaxation phase. And if we can do this over and over again, we can reteach the nervous system. We can change that plastic connections between sympathetic nervous system overdrive and pain, and bring it back to a safe place. Sleep is very important in chronic pain, and the manual includes stimulus control pearls for sleep. We are in a very hyper-aroused society with lots of stimulation from computers, screens, such. And these 8 pearls allow patients to relax the nervous system and get better sleep. And this has been shown to be, stimulus control has shown to be as effective as medications for improving insomnia. So we're running out of time here. I'm going to get back to Kate. Now, a year later, Kate's been doing well. She's been doing her yoga. She's been doing her mindfulness. She's been walking. And then, unfortunately, one of her daughters becomes ill. She stops doing her activities. And then, because she stopped doing her activities, when her daughter gets better, she says, oh, I need to go for a run to get back into shape. Well, of course, that's back to her usual pattern. She gets worse, and she comes to see you in a lot of pain in her glute and her calf, requesting Tylenol 3 for her pain. So this is a very common request, patients coming in with an acute on chronic exacerbation of their pain, requesting medications for their pain. So let's turn to medications. Well, the first thing we can do is recommend, if we're going to prescribe medications, if the above things that we talked about are not going to work for them, we can recommend over-the-counter medications, and here's a list that is available in the manual. Be careful about how much patients use of these medications. I do find that patients are overusing acetaminophen and ibuprofen, especially. Medications for chronic pain do work. The neuropathic pain medications include duloxetine, venlafaxine, the triptylines, and the gabapentinoids. The numbers needed to treat are reasonable, between 5 to 20 patients to get a significant pain response. And I do recommend that you try to use them in a situation where you have a 2-for-1, such as if there's a sleep issue, you can use the tricyclics. If there's a depression or anxiety issue, trying the venlafaxine or duloxetine. And if it's a pure pain issue, gabapentin, pregabalin. So they do have a place in chronic pain management, and they can be used to reduce opioid use. So opioids. We don't have a ton of time to talk about opioids, but it's very clear from studies and now recognized by the Canadian opioid guidelines that opioids are not a reasonable treatment for chronic non-cancer pain, and they can cause more problems than they solve. The issues with opioids are their side effects. They can cause mental impairment, which is what we're trying to avoid in these patients. Androgen deficiency, which can cause fatigue and worsen fatigue and sleep. And of course, addiction. And this concept of opioid hypersensitivity syndrome, where the beta endorphins in the body are further reduced by the exogenous opioids, and patients become hypersensitive to pain. And you'll notice this in patients when you up their dose, they're actually, when they come back to you, they're not any better, and they may actually be worse. The treatment in that situation is to remove the opioid. And of course, opioids are increasingly causing fatalities. So an alternative to opioids is low-dose naltrexone. So low-dose naltrexone is taking a 50 milligram tablet and compounding it down to a very small dose. It works via a variety of mechanisms, such as increasing the endogenous opioids and decreasing cytokines. And this attacks both of the problems in central sensitization. By increasing the beta endorphins in our system, it can lessen pain sensitivity. And by acting as an anti-inflammatory in the nervous system, it can affect the microglia and thereby turn down the pain hypersensitization. Now, naltrexone comes in a 50 milligram tablet. I recommend starting at 1.5 milligrams every day for 1 to 2 weeks, and then slowly going up. Now, because this is a compounded medication, it's often not covered. It can cost somewhere between $50 and $80 per month, depending on your pharmacy and the dose you're using. The main side effect seems to be sleep disturbance, but it's generally well tolerated, and I've seen many, many patients with central sensitization do really well on low-dose naltrexone when used for chronic pain situations. Finally, we're going to talk about cannabis. This is a whole nother lecture, but briefly, cannabis is more and more being used by our patients to treat pain. It's is the number one reason for patients to use medical cannabis. The two main chemicals in cannabis are THC, which is the intoxicating portion, and which can be good in neuropathic type pains, and CBD, which is non-intoxicating and is often used in the central sensitized state. So I'm going to talk briefly about CBD, cannabidiol. It's an anti-inflammatory. It reduces anxiety. It It also has some other properties. It might have some anti-cancer property. It can counteract the negative effects of THC. It tends to be non-sedating, although some patients will say it relaxes them so much that they can fall asleep, and is non-addictive. If you're reluctant to use cannabis and you feel like it's not in your comfort zone, think about this. Deaths in 2016 in Canada from opioids were 2,458, but from CBD, there were 0 deaths. So maybe try, the next time your patient comes in, recommending CBD. And if you're going to do this, you could, the one option is to try 10 to 30 milligrams, either as a tincture under the tongue or as an oil under the tongue, or edible, or in a capsule, 2 to 3 times a day. Now, many patients will respond to this, and it has been shown that it has reduced opioid use in studies. Topicals. Finally, I'm going to talk about topical medications. Topicals could come in a variety of different formulations: anti-inflammatories, nerve blockers, muscle relaxants, and even cannabis is now coming as a topical. Do topicals work? I believe that they do, and I believe that they work using the theory of cognitive behavioral therapy. First of all, by rubbing a medication on yourself, you're doing a behavior rather than taking a pill passively. You're actually rubbing a sore body part. It can change your thoughts by making you feel that you can treat yourself. And it can change your feelings by helping you feel confident and empowered and in control of your pain. So I do recommend topical treatments, especially when trying to get off opioids. Which one you use, it hasn't been really worked out, but they all seem to have some effect. So we're just going to end here with Kate. So Kate comes in again with pain. You can see her BPI now. Her pain has reduced. She's not circling the whole body. The pain is still in her glute and down her calf. She's walking 3 times a week. She's sleeping. She's only using her sleeping meds once, twice a month. She's doing yoga and meditation, and she is seeing a counselor to talk about her traumas in the past, and she's working part-time. So for me, this is a success. Chronic pain is a chronic condition, and we're going to have ups and downs. And the fact that we have Kate back to work and she's doing her activities and not using opioid medications is a win. So in conclusion, chronic pain is common. Central sensitization is common. It's fairly easy to diagnose. If someone has pain all over, has mental cloudiness, and is having trouble sleeping, and all the other investigations have come back negative, then think central sensitization. It is difficult to treat, but it's not impossible. Although the gold standard is an interdisciplinary clinic, there are lots of non-opioid options that can be tried and lots of things that can be given to patients to help them feel empowered towards self-management and recovery. And these are the resources. You feel free to point to your patients towards my websites. These are some YouTube videos that I show to patients. There's a great one about central sensitization. It's about 10 minutes long. LDN, patients can actually compound their own LDN fairly safely. And one moment meditation is a great YouTube video that shows patients how to meditate. And I thank you once again for listening, and please contact me if you have any further questions.
Thank you, Dr. Kailia. We did have a lot of questions to go through, so to our audience, if we don't get to your questions by the end of the hour, we will send a follow-up email with the recording as well as the slides. If you have any questions, please enter them to the question box on the GoToWebinar panel, and we'll answer them aloud. A few of the questions were regarding the website for the free manual, and I see that's at riseabovepain.ca. Is this available in French, and is it available to the public as well as doctors?
That's a great question. So the manual is available for free for patients and physicians. At the moment, it's only in English, but that's a great point. We live in a bilingual country, and I will look into translating it to French. It was supposed to be up today, but ironically, my editor had a terrible migraine, and so it will be up for in its fully edited version by the end of the week. So please check my website this maybe early next week, and it should be there.
Okay.
Paper copies will eventually be able to be ordered, but the PDF is free.
Another question, do you believe neuroplasticity has a place in the self-management of persistent pain?
So I think neuroplasticity is the key to the whole phenomenon. My slide on the perception of pain showed that the areas of the brain involved in attention and emotional response are highly activated in central sensitization. And a lot of these techniques that we're using, such as mindfulness and yoga, exercise, SMART goals, basically all they're doing is reducing the plasticity of the brain, allowing the brain to go back to its resting and painless, not painless, but painless state. So I think neuroplasticity is the key. And I think these techniques that we talk about do reduce neuroplasticity over time.
Okay, another question. Have you heard of laughter yoga, and do you think it has a place in the treatment of persistent pain?
I love laughter yoga. It combines the mindfulness, the breathing with the laughter, which has been shown to release endogenous endorphins. So patients often say they feel high after a laughing yoga session. I think if it's available in your community, that's great. There are some YouTube videos that patients can follow along with and try laughing yoga. Yeah, I think it's a great combination.
Where is your talk on cannabis and pain, and how can we attend?
Oh, that's a good question. So I'm giving it to local doctors here in the Kootenays. It's in Castlegar. If you are in the Kootenays, please check your local CME. And maybe we'll do one for Pain BC one day, and we can have it recorded and on webinar available for the public.
Be great. If a patient is ingesting pain medication and is comfortable moving to topical, how easy is the switch? Have you seen any regression?
So I would say that topical medications should be used as you're trying to taper down a medication, as kind of a bridging. So if someone is only on oral opioids, for instance, and you're working with them to reduce their opioids, adding these things like the topical and the SMART goals and the meditation as you're reducing the opioids is the best strategy, rather than waiting until they're off the opioids and then trying to catch up. So as early as possible, adding other things, substitutes for opioids, will make it more likely that you'll succeed.
Do you differentiate between patients with central sensitization and somatization? Are these the same patients?
Well, I would say that they are the same patients. I mean, they may have different, the focus might be slightly different, but and the treatment is the same. The patients getting out, the meditation and the yoga allows somatizing patients to experience their body in a calm, safe environment, and that allows them to let go of the feeling that there's something terrible in their body. The empathic statements that we make to patients can also help have them let go of those thoughts that there is something terrible. But the catastrophization goes along with both central sensitization and somatization. And that's what all of these techniques are working on, is reducing the catastrophization and improving the feeling of self-management.
Another question. How do we convince people to follow the multidisciplinary approach when they can sometimes believe that pills solve the problem?
Yeah, well, that's a tough one. One way I approach this is when a patient comes to me and their BPI, the brief pain index, which I again strongly recommend that you use, is right shifted, meaning all along the 9s and 10s, and they're asking me for opioids, and they said that they work. I point to the brief pain index and I say, well, I mean, you're not working and you can't really walk anymore. So how are the opioids working? And they say, well, it reduces my pain. And then I try to explain that it's our job to improve their function, and that opioids don't improve function.
And they may improve in some patients, the subjective feeling of pain, but they don't improve patients' lives. And this is a tough talk, and I do this every day, and sometimes you're not going to win. But I think just kind of reiterating that we're trying to improve what you do in your days and redirecting them back to their SMART goals. So rather than concentrating on your pain and what you can't do, let's concentrate on what you can do. And slowly getting them back to their activities, I think, is the best that we can do in these patients who are fixated on opioids.
Okay, great. I think that's all the questions we have for now. If any come in, I will submit them to you by email, and we'll answer them in the follow-up email. Dr. Kailia, do you have anything you'd like to add at the end of your presentation?
If anyone has if they want to correspond with me directly, my email address is drjkailia, it's drjkailia @gmail.com. I'd love to hear from anyone. And yes, thank you very much for inviting me. And I hope we do this again.
Thank you, and thank you so much for your presentation.